Bismillah ar-Rahman ar-Rahim. Our lecture today, the sixth one, about the genetic disorder in orthopedics. And we're starting by the commonest one, what's called osteogenesis imperfecta. Osteogenesis imperfecta it is a relatively common connective tissue disorder with an increased incidence of approximately 1 per 20,000 at birth. It's a mutation of the collagen 1A1 and collagen 1A2 genes cause qualitative and quantitative abnormalities of type 1 collagen productions. The collagen type 1 usually is the commonest one in the bone, leading to a condition in a form of osteopenia in a fragile bone, like erectus bone, liability to fractures, and laxity of ligament. Also, blue discoloration of the sclera. Dentinogenesis imperfecta and considerable variations in the severity of expression of these features and in the pattern of inheritance. The clinical manifestations are usually determined by the individual pattern of the type of the osteogenesis imperfecta. Quantitative abnormalities of type 1 collagen formation lead to a milder form of the disease, while a qualitative defect can cause severe abnormalities in which there is a complete absence of the lamellar bone structures, and lead to the mosaic bone distributions. Here you see the soft bone and bone of the bone like a wall structures, so the usual child can turn crawled with lower limb on the upper limb, crawling like a worm. This is soft bone liable for fracture and deformities. Here the dentinogenesis, you see. Classic type 3 form of osteogenesis imperfecta. Typical deep blue sclera in the type 1 disease. The cause of blue sclera is the reflection of the light on the retina, because the sclera is transparent. Faulty dentin in the patient with type 4 disease. This is dentinogenesis. Silent classification of osteogenesis imperfecta according to the type, associated features of it. Type 1, mild osteogenesis imperfecta with a blue sclera, possibly with a premature deafness, and it is autosomal dominant. Type 2, perinatally lethal, usually the newborn die on birth. Type 3, severe multiple fractures, progressively deforming on autosomal recessive. Here you see autosomal dominant, usually milder than the recessive type in most of the genetic disease orders. Type 4, mild to moderate osteogenesis imperfecta with wide sclera. Type 1 is a mild form, the commonest variety, and over 50% of all cases constitute about type 1. Fracture usually appears within 1 to 2 years of the age, and healing is reasonably good, and deformities are not marked. Sclera deep blue, and teeth usually normal, but some have dentinogenesis imperfecta and impaired hearing in adult. Quality of life good, normal life expectancy, and it is autosomal dominant inheritance. Usually we're facing this type of disease, which is the commonest one, and usually they live into adult life. Here you see the sclera, bone of the limb sometimes shortening, and the teeth affection, and so on. Type 2, which is lethal, usually about less than 10% of the cases, intrauterine and neonatal fractures, large skull and wormian bones with sclera grade, rib fractures, and respiratory difficulty. Stillborn or survive for only a few weeks, and mostly due to the neo-dominant mutation, and some are autosomal recessive. Type 3, severe deforming type. It's uncommon, less than 5% of the cases, frequently fracture during early childhood, deformity is common, and sclera secondary pale, flu, or normal. Intelligence imperfecta survive to adult life with fairly good function. It is an autosomal recessive, a dominant. And here the type 3, it is usually near the type 1 in its presentations. I like type 1 in the presentation. Type 4, moderately severe, the classic but not the most common form of osteogenesis imperfecta, fracture often present at birth. Dark skull, warming bones, pinched-looking face, marked deformities, and kyphoscoliosis by the age of 6 years, usually, and sclera gray becoming white, dentinogenesis imperfecta, a marked joint laxity, respiratory problem occurs, and poor quality of life if you survive to adulthood, and sporadic or autosomal recessive inheritance. You see, it's a problem. Cases, osteogenesis imperfecta, the shape of the face, and the side of fractures, commonly, and affection of the teeth also occurs. It is autosomal dominant inheritance, most common, but reproductions by environment persons, rare in incidence of sporadic cases. Radiograph showing very thin and osteoporotic bones. Fracture rate is high, and here scoliosis spine, severe scoliosis, deformities. How we manage this case? Genetic manipulation is no more than a promising for the future, and conservative treatment is directed at prevention, usually by family planning, advice about the marriage with the relatives, and usually is a form of manage the family and arrange the family productions and survey of the relatives, and it's a preventive measures because there is no therapeutic therapy or therapeutic management for this disease. Supplementage usually for treating the fractures when they occur. However, supplementage should not be overdone, as this may contribute further to the prevalence of the osteopenia. So it's a controversy, but usually an acute attack of fracture, usually we use supplement in a form of cast or bracing and so on until the starting healing, then advise movement because they are liable to the more osteopenia and osteoporosis. General measures to prevent recurrent trauma and maintain movement and encouraging social adaptation are very important. Child with severe osteogenesis imperfecta may be treated medically with cyclical biphosphonate to increase the bone mineral density, like an treatment of osteoporosis, and reduce the tendency to fractures, but immobilization must be kept to a minimum. Here, osteogenesis imperfecta with bung of the both femori due to multiple fractures, and here treated by multiple osteotomy with intramedullary nailing, what's called kebab surgery. Kebab surgery, cut the bone into multiple pieces, and then by insertion of intramedullary nail inside the bone to maintain the alignment of the bone. Here we complete the osteogenesis imperfecta and come to the second disease, which is also common, which is a mucopolysaccharidosis. That is the polysaccharide glycosaminoglycan, as you know, form the side chains of the macromolecules in proteoglycan, which is a major component of the matrix in the bone and cartilage, and intervertebral disc, synovial, and other connective tissues. As you know, defunction of the proteoglycan can be degraded by the lysosomal enzymes. So, deficiency of any of these enzymes, which are responsible for degradation of the glycosaminoglycan, leading to accumulation of these materials and degraded by the accumulation and hold up by the in the degradation pathway, particularly degraded by glycosaminoglycan, accumulate in the lysosome and the reticuloendothelial system, in the liver, in the spleen, in the bone, and other tissues. and spill over the blood and urine where they can be detected by suitable biochemical tests. Confirmation of the enzyme lack can be obtained by testing on the cultured fibroblast or the leukocyte to define the type of the disease. And the clinical feature depending on the specific enzyme deficit and type of glycosaminoglycan storage or accumulated. At least 6 clinical syndromes have been identified of this disease. First of all, Morquio Bradford syndrome. It is a developmental disorder, and the child usually and the neonate look normal, and the first year or two, also walking may be delayed, and thereafter the child being to look dwarfed with a moderate kyphosis, short neck, and protuberance of the sternum. And there is marked joint laxity and progressive genia valgum. Suitable test will reveal a conductive hearing loss. However, the face is unaffected and intelligence is normal. X-ray of the spine shows typical ovoid hypoplastic vertebral bodies, which end up abnormally flat, what's called flattening spine, or what's called platys pondyli, and peculiarity pointed anteriorly. Odontoid hypoplasia is usual finding. A marked manubrio-sternal angle, almost it's a classic picture or pathognomonic. And here you see prominence of the sternomandibular angle. It's about 90 degrees. Sternomandibular angle, about 90 degree angulations. Here is the pathognomonic features of this disease. And by the age of 5 years, the femoral head epiphyses are underdeveloped and flattening and acetabular abnormality also. And the long bones are of normal width, but the metacarpals may be short and broader than normal, and pointed at their proximal ends. These are the classic picture or logical pictures. You can see it on the X-ray. Here the spine, flat spine, flat vertebral bodies, mucopolysaccharides, this Morquio disease, and in comparison with the hairless syndromes, here appearance similar to that of the platys pondyli, and here the hairless syndrome also many of them look abnormal, but it is not so pathognomonic like in the Morquio disease, where the manubrio-sternal angle is about 90 degrees. How we manage this case? There is as yet no specific treatment for this developmental or congenital disease. However, enzyme replacement and gene manipulation are possible in the future. Bone marrow transplantation has been used for the last 20 to 30 years. When successful, is halted progress of the central nervous system deteriorations. Some of the clinical features of the condition, but it cannot reverse the neurological damage that has already developed, and it does not prevent the progression of the bone and joint disease. Enzyme replacement therapy is successful in mild cases of the Morquio disease, but it does not cross the blood-brain barrier. Morquio syndrome present several orthopedic problems. Genia valgum may be need corrected by femoral osteotomy, so this should be delayed until the growth has ceased. Coxa valga and subluxation of the hips, if symmetrical, may cause little disability. Unilateral subluxation may need femoral or acetabular osteotomy, like a DDH treatment. Atlantoaxial instability may threaten the cord and require occipito-cervical fusion. These important things. Atlantoaxial instability, because it can damage the cervical part of spinal cord, or the spondylodysplasia carries a risk of atlantoaxial subluxation during anesthesia and intubation, and special precaution needed during operations. Thank you.